Hello everyone, welcome to Amalgam revision classes. In this session we will be seeing about distalization and distalization appliances. In previous exams there were questions that were asked, picture based questions regarding some appliances. So we shall discuss in brief about what is distalization and few MCQ aspects, and we'll look into the pictures of various appliances. So distalization is, as you all know, is a method of gaining space. We are pushing the molars backwards so that we will gain in arch length. So before going into distalization, we'll have to know a little bit about the anatomy of the first molars. So for that, we need to know about the key ridge. So what is key ridge? Key ridge was asked in a question, in an AIMS question before. The exact location of the key ridge was asked. So it was proposed by Atkinson. It is also an MCQ who gave the key ridge. So there are a few questions they are asking about authors. So Atkinson in 1925 gave the concept called as a key ridge. So what is a key ridge? As you can see in this image, it is the infrazygomatic crest. So how is it important in distalization? Key ridge is always related to the upper first molar. So the mesiobuccal root of the upper first permanent molar coincides with the infrazygomatic ridge. So based on this key ridge, the position of the molar can be determined. If the mesiobuccal root is at par with the key ridge, then it means the molar is in the right position. If it's mesial or distal, it means that the molar has moved forward or backward. So why do we distalize? We distalize in two cases. Why are we pushing the molars back? Because they've come forward. So congenital absence or early loss of ease, that is the deciduous second molar, premature loss leads to the mesial drift of the permanent first molars as well as ectopic molar elevation. There will be a class on ectopic molar elevation and its classification and management. We shall see that later. So these two situations, what happens is this first permanent molar that is there moves forward. So what happens? The class 1 molar relationship becomes a class 2 molar relationship. So what we do is we distalize the permanent molar to gain a class 1 relationship. So how do you go about selecting the cases? There are few scenario based questions where they give certain features of the patient and they ask you about the treatment plan. So you need to know that in what all cases distalization is the ideal treatment of choice. One, the patient should have a straight profile, because in distalization is generally not done in a skeletal malocclusion, either in maxillary prognathism or mandibular retrognathism. Distalization is a contraindication. And obtuse nasolabial angle, the patient should have a straight facial profile, good facial profiles, because when we are distalizing the molar, we are going to decrowd and the space that is gained is occupied by the teeth itself and not much of facial appearance is changed. In conventional molar distalization, en masse distalization, yes, the facial appearance will change. When you are distalizing the entire arch, the facial profile is going to change. But when you are doing molar distalization, the facial profile is not much going to change. So you cannot alter the patient's profile. So the patient's profile should be pleasing when you're starting the case. Next, the patient should have a normal lower anterior facial height and also a horizontal growth pattern. So consider this to be a jaw. So this is where the molars are situated. This is something called as a wedge effect. When you are pushing the molar backwards, you are pushing the molar back into the wedge. This causes opening of the wedge. So whenever you distalize a molar, you are going to increase the lower anterior facial height as well as you are going to increase the growth pattern, that is FMA, mandibular plane angle. Both are going to increase. The patient is going to have a long face. So generally distalization is contraindicated in long face patterns and also in open bites. It's going to worsen their condition. So we are not going to do that. Next, what are the contraindication? Like I said, mandibular prognathism, retrognathism, any skeletal class 2 malocclusion, distalization is contraindicated because it is a skeletal, it is not a skeletal, it does not give any skeletal effect, it is only a dental effect. Hyperdivergent growth pattern, like I said, it opens the wedge, It increases the facial height as well as the plane angle. So patients with normal to hypodivergent growth pattern, we do distalization, and we do not do it in severely proclined maxillary anteriors. When you are going to distalize the molars, the reciprocal effect or the anchor loss happens in the form of proclination of the anterior teeth. So already if the patient has proclined anterior teeth, we are going to even more worsen it. So generally avoid in such cases, and severe space discrepancy. In general distalization, you gain up to 3 to 4 mm per side. So if the space discrepancy is more than 10 mm or something, we need to go with extraction treatment plan and not distalization. So this is also an important criteria. Space discrepancy up to 6 to 8 mm can be gained by distalization, not more than that. Next is biomechanics of distalization. So what happens during distalization? The molar moves back, tipping and uprighting movement as well as translatory movement. The force required for distalization is 150 to 200 grams. It could be an MCQ, please remember it. And this is a very important question. They ask this commonly. The center of resistance of molars of the posterior maxillary segment and of the entire maxilla is a commonly asked question. This separately I will discuss in a different session, the center of resistance of different arches. So generally the center of resistance of the molar is between the bifurcation or the trifurcation of the molar, and for the posterior segment it is in the distal root, and for the maxillary arch, just the maxillary arch, not the maxillary bone, it is between the two premolars. For the entire maxilla, it is near the infrazygomatic crest. So this is very important when you give such appliances. You're going to give a maxillary distalization appliance. So the force should be along the center of resistance of the molar. Then only the molar will move bodily. Otherwise, if you give it at the below, you will develop something called as moment, which will cause tipping of the molar and it will not move bodily. So these are the basics you need to know about distalization for your examination point of view. So we'll go into the appliances that are used for distalization. Usually the appliance, the name of the inventor who gave the appliance, and the image you need to know. So distalization is generally done by either extraoral or intraoral appliance. Extraoral appliance is, you can see, headgear. Headgear was initially used before the advent of intraoral appliances. It's like this. We'll discuss headgear in detail as in the form of an extraoral appliance session. So I'll just tell you in brief about headgears. So headgear can be of 3 types: cervical pull, high pull, or combi pull. So all these 3 types of headgear can be used for distalization based on the position of the strap, cervical pull or high pull. The molar is going to intrude or extrude. We'll discuss the biomechanics later. So headgear was initially used for distalization for pulling the maxilla back in cases of maxillary prognathism or restraining the maxilla like it was called before. But nowadays patients generally do not want to wear such extraoral appliance because it's highly dependent on the patient's compliance. Also they are socially conscious that it should be inside the mouth. So then came the intraoral appliances. It's patient compliant because it does not require the patient to do anything to it. Number 2, it does not show out outside. So first, one important appliance that is been used for a long time for molar distalization is the pendulum appliance. Pendulum appliance, you need to know, was given by J.J. Hilgers. This is one MCQ point. So what is it made of? Pendulum springs are made of O32 titanium molybdenum alloy wires. These wires are the ones that are used for pendulum appliance. So this is the construction of a pendulum appliance. It contains a Nance palatal button for anchorage, 2 supports on the premolars, and 1 pendulum spring. So this pendulum spring we activate I'll just show you. This is how it is activated. The arms are extended posteriorly 90 degree parallel to the mid-palatal suture and then pulled and fixed into the molar tubes. So this TMA wires have a good amount of memory. So what happens is when you are going to push it back, the activation will be there and the molar is going to move distally. So this is how the molar distalization works. These arms are pulled back and inserted into the molar tube. So what happens with the pendulum appliance? 1. The maxillary molar is going to move back. Distalization is going to happen. Distal crown tipping is going, it's not going to be a bodily movement because you're not giving the force along the series of the molar. You're going to give it on the molar tube, which is at a lower level than the center of resistance. So what happens is the molar is going to tip and also it is going to intrude. The distal side will intrude, the mesial side is going to extrude. That's what it means. Next, the premolars are going to move forward because there will be a reciprocal effect. The molar is literally pushing the premolars front and going back. So what happens is there is a movement like this. The molars are moving like this, the premolars are moving in the front. Not just the premolars, the anteriors are also going to flare. So it's like the molar is pushing the entire arch front and moving back. So that's what happens in molar distalization. So proclination of upper anterior is seen. So maxillary second molars, if they are present, are also tipped distally. So generally 1.2 mm per month is the mean rate of distalization that happens, and 200 to 250 grams of force is generated by a pendulum appliance. You need to know that. So skeletal effects, there is no skeletal effect. That is why it's not given in any skeletal malocclusion. There is an increase in lower anterior facial height. Like I said, the molar tips back, so there is a mesial cusp hangs down and it causes opening up of the mandibular plane angle. Next, there are various modifications of these pendulum appliances. I'll just show you a few diagrams because they might ask these appliances images and ask you what this is. So something called as pendex appliance. Generally in class 2 malocclusion, not just the molar moves forward, the arch is also constricted. So what they want is, first they want expansion and then distalization. So this appliance incorporates both so that you can do both simultaneously. You can expand as well as distalize at the same time so that you can save time. So pendex is nothing but there is a jack screw. Jack screw attached to the midline of the Nance palatal button, and this is the normal pendulum springs. So this jack screw, if it is there, it is called as a pendex appliance. Pendulum expansion appliance. That's why it's called as a pendex. Next is called as a penguin pendulum appliance. Penguin pendulum appliance does not have a skeletal expansion. It has a distal extension like this, like a flap of a penguin's tail. That's why it's called as a penguin pendulum appliance. And there is a pendulum spring. This is added to put more anchorage so that there is less anchor loss within the appliance. Next is something called as a Grumrax appliance. Grumrax appliance does not have a acrylic. It is an RME screw that has a soldered arm to the premolars and a pendulum spring to the molars. So Grumrax appliance, pendex appliance, the difference is that there is no acrylic button, but the same expansion screw is there. T-Rex appliance. The only difference between the T-Rex appliance and a pendex appliance is the attachment to the molar. In a pendex appliance, the attachment to the molar is not there, but in a T-Rex appliance, there is an attachment to the molar. That is all the differences. It's the same appliance and just a small modification. They will show you, generally give a picture, and they will generally not give you these two options in the same question, so you can go with the answer properly. So it's the same thing. Premolar is there, and there will be an attachment. You can see here it is attached to the molar like this. This attachment will not be there in the Pendex appliance. That's the only difference. Next is something called as a K pendulum. What is a K pendulum is, this anchor loss is a very difficult problem in distalization, because the anteriors flare up, the premolars move front. The distalization also happens in that way. They do not want the anterior segment to move front. So what they did is they separated the Nance palatal button and the pendulum springs so that they are not connected. This is a distal screw. So when you activate this screw, this whole segment will move back, including the pendulum springs. So it adds to the distalization effect. This is something called as a K pendulum. You just need to remember the images. They will never ask you in detail, because this is all postgraduate syllabus. These pictures are also from postgraduate textbook only. This will not be available in your undergraduate books. So just because they had asked a similar appliance in the AIMS, the recent NSET exam, I have added all these pictures for you. But you just need to remember these images. These are the modifications that are available, and you need to know. That's it. This is a bone anchored pendulum. If you see a pendulum spring and an implant like this, it means that it's a bone anchored pendulum. Like you see in this picture, there is no arms into the premolar. All the distal force is taken up by the implant, so that the anteriors do not flare. That's all. Next appliance is the distal jet. This is also most commonly asked image question. Pendulum appliance, distal jet, very common. Mostly they'll ask you, if they ask any distalization appliance, it's going to be either pendulum or distal jet most of the time. So distal jet, there is no pendulum spring. You can see here, there is a screw here and there is a coil spring. So when you push this piston forward and tighten it, this coil spring is going to push the molar backwards. That's how distal jet works. It was introduced by Carano and Testa. You need to remember the author's name. Pendulum was given by J.J. Hilgers, and distal jet was introduced by Carano and Testa. So you see a screw here and a coil spring here. It's a distal jet. It's attached to the premolars and contains a button. Next is another type of distalization appliance called as Keeley slider. Keeley slider is very similar to distal jet, but it has a anterior bite plane kind thing. Distal jet has a bite block here. A Nance button here. But Keeley slider has a button in the front, like an anterior biplane. Same screw and a Nite coil spring. Same principle. It delivers force along the series of the molar so that the molar moves bodily. Since it's away from the molar, you can see. Next is the fastback appliance. This appliance was asked in NSET 2021 May exam. This appliance most of you must not have seen, because it's a little out of syllabus for undergraduates, but still it was asked. So this appliance has two expansion screws, vertically oriented, so that when you open this screw, this acrylic part splits and the molar distalizes. It also has attachment containing a Nite coil spring that is activated. So what happens is the molar distalizes backwards. So this is something called as a fastback appliance. Just remember the appliance, the images. When you're reading through it, just see the images for you. We'll put up all the images in the app, in the image bank. Next is something called as a Jones jig. This is also a very important distalization appliance, but a buccally positioned distalization. All the appliances were positioned palatally. This Jones jig is a buccally positioned distalization appliance. There is a Nite coil spring here. They will pull and tie it to the molar so that this Nite coil spring will push the molar backwards. This was called given by Jones, so that's why it's called as Jones jig. Then they might also ask you about magnets. Magnets are also used for expansion, distalization, space closure. So for distalization, these two magnets are used. Samarium cobalt magnets and neodymium boron iron magnets are the most commonly used magnets. If they give you an appliance like this, two blocks tied together, then this is a magnetic distalization appliance. there is an appliance called as first class appliance that uses magnets as a part of its setup. Something called as carrier distalization. This might also be asked as an image question. Just a rod connecting the molar and the canine. How do you activate is you give a class 2 elastics from this to the lower molar. This appliance will push the whole segment, canine to molar, backwards. So this is one such appliance. It's like a hand shower, but it's called as a carrier distalizer, one of the recent advances in distalizing appliances. Next is the first class appliance. Like I said, you can see here the magnetic attachment, and in the front setup you have a coil spring. So this is called as a first class appliance. It's a combination of both buccally positioned as well as palatally positioned distalization appliances. So next is your TPAs. TPAs can also be used for distalizing. You can activate, push the TPA front, pull it back and engage, but it is mostly commonly used for correction of molar rotations and as space maintenance you would have studied, and as well as maintaining the anchorage. So there are two types of TPA. TPA was given by Gauge-Garian, commonly asked question, who gave the TPA? It's Gauge-Garian. It's also called as Gauge-Garian's arch. Transpalatal arch is also called as Gauge-Garian's arch, and Zackerson modified this Gauge-Garian arch, gave an extra loop to increase the flexibility so that the forces are milder, and this is a Zackerson's modification of the TPA. So these are all the appliances that can be asked. There are more, but I feel it's more in the postgraduate level than an undergraduate. So I've added these. All images will be added to your image bank soon, so you can check while revising. You can check out these images. So we'll discuss just few MCQs regarding distalization. Not much has been asked in distalization. More of expansion has been asked, but distalization you can few questions may be asked picture based, or few scenarios. We'll discuss them. So methods of teeth distalization are all except they have given you options: headgear, Jasper jumper, Hyrax, pendulum. You all know Hyrax is a RME appliance and not a distalizing appliance. So clearly the answer is a Hyrax. But you also see Jasper jumper. Jasper jumper is a fixed functional appliance, right? Why does it help in distalization? There are few appliances that also cause distalization in addition to mandibular forward positioning. Those are the fixed functional appliance. Fixed functional appliance do produce distalization. So for this only reason I added this question, because fixed functional appliance, if you see Jasper jumper, you will immediately jump into the answer without reading the next option. So Jasper jumper or any other Herbst, whatever it is, if they do give molar distalization as a reciprocal effect. They are pushing the mandible forward. The same way the maxilla is also going backwards. So molar distalization happens in such cases. So in such questions, read the options carefully and then answer. So identify the appliance, very commonly asked question. You can see it's a pendulum appliance. So you can see the Nance button, the pendulum springs, no expansion screw, nothing. So it's a pendulum appliance. There's no implants, rests on the molar. A conventional pendulum appliance given by J.J. Hilgers. So this is, I added a case scenario to just tell you how we end up with distalization. So a 15-year-old patient presented to the clinic with a chief complaint of irregularly positioned teeth. On examination, the chief complaint is irregularly positioned teeth. So that's one. On examination, the patient had class 2 relation, a space discrepancy of 6 mm in the upper arch and 2 mm in the lower arch. The patient had a straight profile. So they are giving you information. You need to collect it. When you're doing the exam, just write it down. So irregularly arranged teeth. So the patient has not complained of a proclination. 1. The patient has a class 2 relation, class 2 molar. Then space discrepancy in the upper arch is 6 mm, lower arch is 2 mm. So they have given you cephalometric values. SNA is 82 degrees, SNB is 81, FMA is 24. So these are the information we have, and we need to come up with a treatment plan. Generally, sometimes they may give you cephalometric values, or they may just tell you the mandible is retrognathic, the maxilla is prognathic, like that. So whatever it is, we need to just write it down so that you tick all the points. So extraction of the, what's the first option given? Extraction of the upper and lower fours. 1. The patient has a straight profile. When you're going to extract the teeth, the patient should have a bimax profile. So the patient has a straight profile, so no. Plus the space discrepancy is 6 and 2 mm. If you're going to extract one premolar on one side is 6 mm. So when you're extracting both premolars, you'll be ending up with 12 mm of space in the upper arch and the lower arch, and the space discrepancy is not that much. So for those reasons, it's not an extraction case. Next, BSS or advancement of the mandible. If you see a surgical options, jump straight into the cephalometric values. SNA 82, SNB 81, it's normal. 82 is normal. 81 SNB is also normal. It is not a case of skeletal class 2 malocclusion, it's a dental class 2. So no surgery. Twin block. Twin block, it's not a skeletal case. And also the patient complains of crowding. Generally twin block is not given in crowding cases. And the patient is 15 years old, so almost the growth is at the verge of completion. So it's not a case of twin block because there is no mandibular deficiency. There is no no information regarding the mandible is given. If there is any deviated path of closure or something, nothing is given. So it's not twin block, it's distalization. It's a dental malocclusion. The skeletal parameters are normal. The patient is safe. Slightly hypodivergent growth pattern. Space discrepancy is correct. If they have given IPR, maybe IPR also would have worked for this patient, but 6 mm is a doable amount of space for distalization. 6 to 8 mm can be achieved by distalization of the molars. Class 2, yes, that's because of the molar mesial drifting. Patient has a good profile, yes, irregularly arranged teeth, so the space created can be used for crowning. So the answer will be distalization of the upper molars. So this is how you go about doing a case scenario in ortho. Write it down, what are the points, and then match it with the options. So that's how we go about. We'll discuss more case scenarios in upcoming sessions. So this ends the session for distalization. I hope you all got to know few things about distalization. We'll discuss more topics. So thank you.